Hello, I'm Michael Lobatz. I'm a medical doctor and neurologist here in San Diego County. I've practiced for more than 35 years. I am blessed to be the clinical lead or director of the clinical roundtable for the San Diego County Alzheimer Project, and I'm on the steering committee of the San Diego County Alzheimer Project as well. The Alzheimer's Project was conceived by Supervisor Diane Jacob and others for the purpose of helping this great public health problem that is upon us now and going to get worse over the next 10, 20 years, and that is the increasing incidence of Alzheimer's disease in our population here in San Diego County as well as the country and even worldwide. Currently, there are 63,000 patients with diagnosed Alzheimer's disease in San Diego and about 150,000 or more caregivers associated with that group of people. So you can see that this is a great public health problem that's affecting a significant percentage of our population. One of the things that I've noticed and others have noticed over the years is that there has been a lack of standards of evaluation and diagnosis methods for determining if a person has a form of Alzheimer's disease or not. And one of our goals in the clinical roundtable for the Alzheimer Project was to actually create some algorithms and some standards by which primary care physicians, primarily, could easily access and perform their duties in a timely fashion in their office and diagnose or reassure patients about their memory concerns. The primary care physician today is extraordinarily busy taking care of a variety of different kinds of medical conditions, including diabetes, high blood pressure, cholesterol, and a variety of other things. And for us to be able to sit down as a group of physicians, psychologists, psychiatrists, social workers, geriatricians from around the county representing multiple systems of care, including Scripps, UCSD, Kaiser, Sharp, and others. And for that group to be able to sit down and create some easy method for a primary care physician to actually adopt a screening tool that might only be a few minutes in the office to determine whether or not further steps are needed to be able to diagnose and then ultimately to manage patients with Alzheimer's disease seemed like a very worthy endeavor. As a result of 2 years of work with the systems that I've already mentioned, and great input from professors and from clinicians, psychologists, and people with large amounts of experience in evaluating and treating Alzheimer's disease, we were able to create algorithms for the screening of memory disorders to determine whether an individual needs further evaluation or not, and then actually to create an evaluation algorithm which would take a physician through what needs to be done, and then finally, with the help of our psychiatric colleagues and neurologists from around the county, create standards for looking at how to treat various aspects of Alzheimer's disease, including things that are so troublesome like depression, anxiety, agitation, and psychotic behavior that can occur, and is often a reason why people end up in skilled nursing facilities or in hospitals or have multiple complications. I'm here to talk to you today about some of the things that we've been doing and the importance of how we are going to assist primary care physicians in their tough job of taking care of patients. There are so many patients with Alzheimer's disease that it's impossible for specialists to really evaluate and take care of all of them. And the idea of our clinical roundtable in terms of gathering the neurologists, geriatricians, and other physician leadership from all of the systems here in San Diego County was to come up with an algorithm and a plan and a way to assist primary care in screening and diagnosing patients with memory loss and Alzheimer's disease. The physicians that are primary care doctors, including family practice, internal medicine, and others that deal in primary care, it's incredibly important, and they're critical to this in terms of being able to evaluate and treat ultimately these patients at a later point in time. We wanted to create simple and effective tools that would be rapidly used and only take a few minutes of your time in terms of evaluating and screening patients in particular for memory disorders. So the algorithm that we've put together, this methodology, is simple, easy to learn, and something that you can incorporate very easily into your practice so that you can screen these patients appropriately. The fact that there are 63,000 patients here in San Diego County with Alzheimer's, and that the #1 risk factor for the development of Alzheimer's disease is aging, and given our baby boomer population, myself included, aging with time, there's going to be an increased prevalence of Alzheimer's disease in our population, and that number of 63,000 is going to dramatically grow over the next 1 or 2 decades or more. Therefore, it's imperative that the primary care physician community of family practitioners, internal medicine specialists, embrace the need to do efficient and validated and literature-based screening, and to do efficient and literature-based and validated evaluation and make the right diagnosis. And it's also important for those physicians to know potentially the limitations of what that process involves and when they need to actually call and speak to a neurologist or get input from a neurological consultant or a psychiatrist in regards to what needs to be done. Not infrequently, patients will come in and say, "Doc, I don't think my memory is as good as it used to be. I'm misplacing my keys. I can't remember names as like I used to. Do I have Alzheimer's disease?" So that's a very legitimate question that might come up from a patient. The physician themselves may notice something different in the patient, especially if they have that longitudinal relationship with them. And in addition, maybe a family member may point it out. And the possibility that this is just normal aging is to be considered. It's also possible that the patient may have early cognitive impairment, what we call mild cognitive impairment, and it's also possible that they're on the road to either developing or have developed Alzheimer's disease. So the screening tool in the office, which only takes a few minutes to do, can help differentiate between that worried well individual that may have normal aging and those that will have more concern, such as mild cognitively impaired patients or patients with true Alzheimer's disease or its related conditions. When a patient presents either with complaints of memory or the family brings them in or the physician notices a change, that's an indication to do the screening tool, the algorithm for that. And a physician should be able to, or even a nurse practitioner or a physician's assistant, can and should be able to perform a screening evaluation in 5 to 10 minutes and be able to determine whether or not that patient needs to be further evaluated thereafter. So when a patient is being scheduled to come in for a visit and you think you're going to be doing a screening visit, or even if you're not thinking you're going to do a screening visit, you're going to require them to bring a list of their medications or even bring in the pill bottles themselves, and to really be sure about what it is the patient is taking from a medication perspective. It's also very helpful, of course, to know the past medical history if it's not already available. So prior medical conditions and surgical conditions. Some family history also needs to be obtained. Is there a long history of cognitive problems in multiple family members? Late onset, early onset, that kind of historical detail is also very important. But most importantly, more than anything else other than perhaps maybe the medication list, is somebody else needs to come with the individual. Because the average individual who has a memory problem usually can't remember that they forget. And you may ask them the question, are you having any problems with your memory? And they may go, no. And one of the more reliable signs, of course, is when the spouse or family member, child, or whoever is sitting next to them and rolling their eyes and looking at the ceiling as they answer that everything's okay. That could be more valid and reliable than just about anything else that you do in terms of trying to learn more about whether there really is a problem or not. You may want to ask about driving and about whether or not there have been any accidents or getting lost or things of that nature. So those are things that family members can come with information about and speak hopefully frankly about that, or even if they can't speak frankly in front of the affected individual, to even give the physician a little note regarding their concerns or give the physician some input in regards to that. So I think medications are really extremely important. We need to know what they're on, a little bit about the medical history, some family history, and then a validated observer, somebody that can really tell us, is this really truly a problem or not, and have other people really notice this difficulty. We're challenged by the electronic medical record, needless to say. I can't stop thinking about my typing teacher in high school who told me to learn how to type when I was 14 years old, and how I thought that that wasn't something that I really needed to learn, and I paid the price of that. But now, using keyboards and computers is incredibly important, but what it does, as you well know, is when your head is buried in that computer, you're missing out on an interaction with your patient. Given that Alzheimer's disease and other forms of dementia are associated with depression and behavioral change, that eye contact, that time, even a few minutes, spending with the patient, looking them in the eye, connecting with patient and family, watching body language, watching the body language of the caregiver, and so forth, can be incredibly revealing to you in your further evaluation or even decision as to whether or not you should evaluate a patient. So we hope that these things that we've put together help you reduce the time that it takes to get to the decision regarding evaluation or treatment of a patient. And also we hope that some of the pearls that we can pass along in terms of the behavioral management will be very useful to you, very good for your patient, and improve both outcomes and safety. There are some people that can have mild, true memory complaints, but yet function normally in their environment. And these are people that we call having mild cognitive impairment. And the concern about mild cognitive impairment is that a certain percentage of those patients will go on to develop Alzheimer's disease or another form of dementia. So knowing how they are doing and how they're focusing in their environment is extremely important. Another real important reason for identifying these early onset cases is the fact that we think now that the way we're going to help change the course of Alzheimer's disease is to identify these early patients. And right now we're going to, of course, getting them into clinical trials with new medications and strategies for treating, like anti-amyloid strategies and things of that nature. And we think that that's the group of individuals, that early onset, that are going to benefit most from intervention. Of course, it's also important from the point of view is knowing that you have a potentially fatal disease that has a time course of 9 or 10 years is incredibly important information for the patient and family in terms of planning for the future.